Anong room temperature?
30 ulam.
45
Same din naman. $32. 10:02 a.m. Yan yan, di ba?
Sa babawasan ka.
Ano, low? That 1 to 3 cm, sir.
Uh, 35.4. Pagka-adjust ka na.
O, yun na yan. Bako, pero ang temp mo, B, gamit itong ano? Kurani mo.
4.9. Baba na lagot. Tigbawas akong 2 degrees kada adjust.
Dahil dapat ilan mo na dapat 1 to 3 cm.
Yan ang ginawa niya. Kasi gano'n yan.
Bakit ba siya mag-picture?
Ay, dali. Grabe ka.
Sensya lang parang sympathy.
Good morning, everyone. We're going to start the webinar very soon. I would like to request everyone to mute your microphones, please. There's a dog barking in the background, and I hear people shouting as well or engaging in a conversation. Good morning, everyone. We're going to start very soon. Please mute your microphones. We have already reached 100 participants for now. For those who would not be able to log in, please give this link, this YouTube link, and they will be able to view this webinar just like everyone is doing. And they can send their questions in as well through the live chat portion of the YouTube, and also here for those who are on Zoom, and we will try to answer your questions as much as we can. So before we finally start, allow me to thank everyone who's joining us today. I am Dr. Catherine Te from the Surgical Informatics and Website Committee. And together with the Board of Regents, we're going to share with you some of the experiences of our colleagues and also what the PCS is doing. Our moderator for today is Dr. Esperanza Lajos, and she will introduce to you all the other participants. But before we start, please let me reiterate some of the guidelines, and we hope that all of you would be able to enjoy this productive morning. The presentations will last for 60 minutes. There will be a question and answer portion in the end for those questions that will probably be applicable to the general audience. For some other specific questions, we will be answering on the background on the chat. So please check on the chat portion as well. Now, please try to mute your microphones as much as you can. And you may raise your hands or send us a chat message if you want to ask a question in the question and answer portion during the open forum. For the presentations, these are all recorded, and we will try to give you another link later on if you would want to go back to this presentation. So again, thank you very much, and I'd like to turn you over to Dr. Lajos for the webinar proper.
Okay, thank you, Kathy. Welcome to the first Philippine College of Surgeons webinar on surgery during COVID-19, what has changed? To start the program, I request PCS Regent Dexter Ison to lead us in prayer. Dexter. Dexter. Oh, Dexter. May I call on Dexter Ison, please?
Yes.
Okay.
Almighty Father God, as we gather here today through this webinar meeting, we humbly ask you to bless us with your presence. Open our hearts, Lord, clear our minds, and give us the opportunity to gain the most from this meeting. As we listen to and learn from each other, send your Holy Spirit to inspire us so we can all work together towards a common goal, and that is to prevail against this crisis. Allow us to do what is best for all. Together with you, O God, we shall defeat this dreadful disease. We ask all of this in the name of Jesus. Amen.
To welcome our participants, may I introduce to you our PCS President, Dr. Jose Antonio M. Salud.
Morning, ladies and gentlemen. On behalf of the Board of Regents of the Philippine College of Surgeons, I would like to welcome one and all for tuning in to this initial webinar of the PCS during this time of COVID-19. I have to, first of all, thank our friends from Menarini, Mia Legaspi, the CME manager, who initiated this webinar, and of course, Kathy Te, our hardworking chair of the website and health informatics subcommittee of the college, along with the telemedicine network of the Philippines for coordinating with us to carry out this activity. Thinking of the situation we are presently experiencing, it is so ironic that it is happening in 2020, which symbolizes clarity, but there are so many questions in our minds that we remain confused, uncertain, and doubtful of what the future holds for us. Despite all this, we remain hopeful, and we know that this crisis will eventually transform all of us for the better. We encourage everyone to have faith that we can overcome all of this with the resoluteness and firmness inherent among surgeons. I would like to honor our fallen colleagues, June Resurrection, Ronnie Mateo, Grace Lim, Greg Makasaet, Sally Gatchalian, and the other physicians, healthcare workers, and all others who have been victims of this deadly virus. We sincerely mourn their passing and lift them up to heavens, where they may rest in eternal peace. The college will continue to be the North Star for all surgeons in times of crisis, a beacon of hope and inspiration. The guidelines and advisories are just a few of what we can offer and provide for our fellows throughout the country. And this webinar is another chance for us to show you ideas for now and for the future. I hope all of you stay for the rest of the hour. We look forward to your presence in subsequent webinars. Good day and keep safe, everyone. Thank you.
Thank you, Dr. Salud. For the first topic, the Philippine College of Surgeons Board of Regents had been frequently meeting since the enhanced community quarantine, and we came up with different guidelines. To give us some perspectives on these guidelines will be Dr. Manuel Francisco Rojas.
Thank you, Panching. I'd like to welcome all surgeons from the PCS to today's webinar, which is going to be probably our next normal. So, and since this is the first webinar, I hope you will give us some leeway on how we use the technology. Kathy, can you allow me to share my screen?
Yes. Please start the share screen.
Not yet. It says only the host can share the meeting, Kathy. I'm sorry.
Try it again. I have turned it on.
Okay, I have it. Just a moment, sorry, it doesn't go Kathy. Sandali lang. It looks like I can't go straight from PowerPoint. I have to share it.
The share screen is on.
Yes, yes.
While waiting for Dr. Rojas, I would like to inform all the participants that there are also guidelines from the different subspecialty societies like PALES, PABC, PSBES, OFTA, ENT, Ortho, Urology. So you just log on to the PCS website at www.org.ph or at the PCS Facebook account. We have several guidelines posted there and other advisories. Dr. Rojas, ready?
Just a moment. It won't load. Sorry, it won't load directly on my PowerPoint. I have to load it to Google. I tried sending it, but it wouldn't send also. I think it's the internet
Gusto mo ikaw
connection.
na mauna? Si Rodney kasi hindi makapasok pa yata eh. Gusto mo?
Yeah, I couldn't load.
Would you like to send?
I tried sending.
Okay,
Would you like
can
to
you?
send your PowerPoints to me?
Okay, while
Yeah, I was sending it, Kathy. Ayaw mag-send. I think it's the internet connection.
okay, can we just proceed with Dr. Roel De Leon? I think
Okay. All right.
he is prepared. So for Dr. De Leon, unlike in Metro Manila, there are other different experiences that we gathered during our dialogues with the different chapters. So Regent Jose Roel De Leon will discuss the perspectives from the province. Roel? Roel, nakamute ka. Hindi ka pa rin marinig.
Okay, so apologies for this technical difficulty. As Dr. Salud has mentioned, this is the first time that PCS is doing this webinar. Please do bear with us as we try to improve and enhance your experience. For sure, this is not going to be the last. So please hang
Okay.
in.
So, Kathy, which slides do you have? Okay, if Dr. De is not yet, we are having technical difficulties with Dr. De Leon. Probably Dr. Gulfan on the training aspect during the COVID-19 can proceed. He was one of the first to log in, so I guess he is ready with his presentation. Dr. Gulfan? Dr. Gulfan? You're on mute. Can you unmute Dr. Gulfan, please?
Hold on.
Dr. Gulfan, you're on.
All right. Thanks for having me and Patos. It is a humbling experience to be sharing with you something. And good morning to all of you who are listening today. Answering the question on what has changed. Our lives has changed, knowing that friends and fellow surgeons died. And our family members and friends have to distance themselves from us. Surgeon friends saying, more take care almost all the time. Friends and staff, all members of the health workers saying take care almost most of the time. And patients calling up and saying take care also. So this is life-changing. Our plans for meetings and conventions have changed also. And definitely we put on hold our meeting supposedly in Bicol, in Naga, because it is affected by the enhanced community quarantine. And for the information of everybody, this ECQ might last until July. And hopefully we will not be so much affected already when the PSGS will come up with the convention. I noticed also that aside from the academics, surgeons in the different medical centers are more supportive of the healthcare systems. The surgeons becoming more supportive of the residents. In fact, more intense in their dedication, giving food, to everyone, sharing food to the residents and other consultants. And of course, donning the very hot PPEs with more grit and at the same time, more humor. I noticed that change is also on the way or has been on the way when it comes to triage or non-emergent surgeries. Many surgeons whom I have talked with from the north to the south, they have their own triage on non-emergent surgeries. And I'm reminded of the elective surgery acuity scale, that the US has according to the American College of Surgeons. Nevertheless, we also have our own elective surgery acuity scale adapted to our setting and to our culture. And many members of the training program also, more on the many, if not all, in the subspecialties also came up with their own triage. Now, the PATOS members have been active in their leadership potential, particularly setting up and organizing CAVID dedicated operating rooms and operating room staff with emphasis on patient safety and safety of all the members of the healthcare system. I understand that we don't have surgical conferences now for each department, but communication all throughout the country is 101%, and the chain of command is very much intact. We also noticed that change wherein senior members of the surgical staff, which are practically 65 years old and above, are now giving their patients to the junior consultants. And that is quite remarkable. And the changes on just bare essentials, no watches, no jewelries, and so on and so forth. I think that is just about it with my 10-minute talk, and the rest of the questions will be answered later. Thank you so much.
Thank you, Jojo. We're having some technical problem. Two of our speakers are not able to, to log in. Can I request some of you to log out first, and then probably
There's an audio
Panching, I can
person.
log in already. I can log in
you
already.
can log in. No, I mean, Rodney and Rami cannot log in because
I can log in already, Panching.
okay. Let us
Sorry.
allow the other two speakers.
Yes. So sorry, Dr. Lahos. Allow me to clarify this. We had some issues with the number of participants. So I would like to request a couple of you to log out first so that Dr. De Leon and Dr. Dofitas would be able to log in. And then after you can shift to YouTube live stream. It is the same, and you can still send in your questions through the YouTube live stream, and we will try our very best to answer your questions. But in the meantime, please allow. Okay, now don't log out anymore because we now only have participants. I think Dr. Dofitas and Dr. De Leon would be able to log in.
Kathy, can you see my
Yes,
presentation, Kathy?
already, Rami. So I'll just let
Okay.
Don and Roel log in, and then you can restart the presentation.
Okay.
Kathy, I'm back. I'm okay now.
Okay.
Thank you.
Alvin, can you please share the screen of Dr. De Leon?
Okay na ako. Oh, thank
Sorry,
you.
Alvin.
Okay.
Let's do Dr. Rami Rojas first since the screen is already on.
Okay, everybody's already logged in. All the speakers I mean have already logged in. So we can now proceed with Dr. Rojas's presentation. Rami?
Yes, just let me log in again.
This is going to
I'm just
be
logging in again. I was told.
now. Okay, this is going to be the new normal.
So there's,
I need all of you to be able to get used to it and know how to get in, get off, share screen, and not share screen and mute your microphones. So this is a good start for all of us. Good exercise, okay?
just a moment. It's not, I can't.
No worries. We will be very patient, and we will get used to this new normal.
Are you allowing me to share my screen again, Kathy? Because nawala yung Zoom button ko.
Yes. Everyone is you're allowed to share.
Okay, just a moment. I got it already, and then now it's gone.
Do you see the share screen button?
Just a moment.
It's either at the bottom or on the topmost
Yes,
part.
yes.
Okay.
The problem is in my buttons. I don't see. It was there earlier, but now it's gone.
What do you mean?
There was a button. No, it doesn't show. It doesn't show. It doesn't show PowerPoint or my slides. But I was able to go through my slides earlier, But now I don't see that button anymore. It said open in Zoom, which I did.
Turn on
Okay,
your.
let me see again.
Okay. Is Rodney in already?
Yes, I'm here. I'm here. I'm here. I'm
Yeah,
here.
Rodney, why don't you go in first?
Kathy, you have the slides of Rodney.
Yes, we have.
Okay, so probably we can
Sige,
start
go
with
ahead.
Rodney. The PGH
Okay.
experience. Rodney can go ahead.
Yeah.
Can you share your screen from your side, or do you want me to share my screen?
Yeah, I have trouble sharing, so I sent to the moderators and to you, Kathy.
Okay, let me check this out. Maybe you want to go ahead with. Okay.
I got mine's copy.
Okay, Rami.
I am so
Rami, go
sorry.
ahead.
Okay, we'll get this. Once we keep doing this, we'll get better at it. Okay, and so I was assigned to present the PCS recommendations that were made, basically by the Board of Regents. So this is not just my work. No, this is the work of the Board of Regents. As we started meeting right after the lockdown was declared on March 16. And these meetings were held over Zoom. And you can imagine the technical difficulties also we had to go through as we tried to create these recommendations as we were all quarantined in our own homes. Anyway, there were 8 recommendations were made during this period. The first recommendation was made in March 14, just 2 days prior to the lockdown. And I think if you look at the screen, and I hope you're seeing what I'm seeing, I can enlarge it for you. At this point, given the directives of the ITF, the PCS Board of Regents was already recommending that we minimize all elective and urgent procedures. And I think and to reschedule all elective procedures for the next 15 days. And I think what we wanted to point out here is this was a very fluid development, and we were adjusting to how the scenarios were playing out. The next recommendation was done on March 15, the next day, recommendations on cancer surgery. And basically, the recommendations was, in summary, there was limited evidence to warrant total cancellation of elective cancer surgery. In endemic areas, a decision on whether or not to postpone cancer treatment are recommended based on patient-to-patient risk factors and underlying comorbidities. But generally, I think we all know that for most elective cancer surgeries, not emergency, but elective, most hospitals and surgeons had decided to postpone these operations. The third recommendation is not actually a recommendation. It was a meeting by the board where we had to make a very sad decision to postpone indefinitely and then ultimately cancel the 46 mid-year convention. And we sincerely apologize to the Bicol chapter for all the preparation that they had done. But really, there's, I think, understandably, nothing we could do at this point. But that was the recommendation number 3 that the board went into. The fourth recommendation, and again, we were responding to the various queries and questions of the fellows as they would come in. The fourth one is surgeries in COVID-free hospitals. And the scenario that had played out was the Metro Manila hospitals quickly got overwhelmed in terms of their emergency rooms and ICUs during the initial surge of COVID-19. And because of that, they had to cancel or postpone other services, including elective surgery, as you know. However, there were many areas outside of Metro Manila where the surge hadn't hit yet, or there were no cases yet. And yet these provincial hospitals were already in preparation of the potential entry of the virus into their locale. So and they had been able to successfully uh, designate both COVID hospitals that would accept these patients in their locale and leave non-COVID hospitals free. So we made these guidelines for COVID-free, or the other term for it is COVID-safe hospitals. And these were the guidelines, no? Strict social distancing, limit, of course, the surgical procedures to emergent and urgent, rotating the surgical teams to minimize possible exposure, the wearing of PPEs, which brought up further questions, and I will talk about that later. And then disinfection practices, prevention of inadvertent contamination. Okay. So that was signed on March 20, 2020. And so the next guideline after the recommendation 4 was really system planning for COVID-19. If a hospital was going to see COVID-19 patients, what would be the systems that had to be in place? So we talked about, number one, reinforcing the capacity to detect and diagnose by having more test kits. We recommended dedicated COVID hospitals because even as COVID is hitting us, our regular load of patients, whether they're cancer, heart disease, acute abdomen, and the like, they're still going to remain. So how do we serve these patients also during this COVID upsurge? So we recommended also separation of facilities for mild cases and setting up of quarantine areas. And really, this was an early recommendation we had made, that to try to segregate hospitals into COVID versus non-COVID. It was not easy to do in Manila already at the time, because most of the big hospitals already had COVID hospitals and COVID cases, and it would not be easy to disengage from these patients. But I think these recommendations also led in one way or another into the designation of the 3 COVID hospitals in government, mainly PGH, the former Tala or Rodriguez Hospital, and the Lung Center of the Philippines. And then we had to, recommendation 6 came about on March 22, 2 days after recommendation 5, talking about for surgery, the precautionary measures that surgeons had to take for emergency surgery during the pandemic. And I think the most important that we wanted to stress is, number one, during the rapid spread of the COVID-19 pandemic, it is prudent to assume all patients for surgery are COVID-19 infected unless proven otherwise. And therefore, appropriate PPE should be worn inside the operating room and strictly by all members of the surgical team. And really, I think what we want to stress even now is the safety of your surgery team is paramount. And that should guide your decisions on whether to operate or not to operate, and that you should be wearing PPEs for all patients. I won't go to the rest of the details of these guideline, because you can read it online. But that basically was the main message we wanted to make, that all patients should be assumed to be positive until proven otherwise. Also, we wanted to also point out that a surgeon who wears the recommended and adequate proper PPE while attending or operating on a COVID-19 positive patient is not considered a person under monitoring. Quarantine at this point is not routinely recommended. Recommendation number 7 came out in March 26, 2 days after the last recommendation. And this one was guidelines on personal protective equipment for surgery, because that was the question that came out after guideline number 6. And again, we wanted to stress that safety of the surgical team is of paramount importance, and there should be no compromise in the use of adequate and proper personal protective equipment. And again, we stated it's prudent to assume all patients for surgery are COVID-19 infected unless proven otherwise. The surgical team is composed, the PPE for the surgical team is composed of the following: a buffer room for putting it on, a hooded isolation gown, double caps, a medical protective mask, preferably N95, of course, medical goggles, boot covers, 2 layers of latex glove, and particularly when there's aerosolization during the procedure, whether it's intubation or tracheostomy, laparoscopy perhaps, a powered air purifying respirator is recommended. And then the last recommendation that the board worked on and is advocating the wearing of face masks for all when we go anywhere, including outside. While the wearing of a face mask is not an alternative to other preventive measures as hand washing and social distancing, when collectively practiced, all three measures help fight against COVID-19. And these guidelines came out roughly at the same time that the IATF came up with the rules that everyone should be wearing a face mask when going outside. And if you look at the Facebook page of the PCS, you'll see this. Actually, it's a video, and I can't play it here, but it's a video on the information about why face masks are important. As these recommendations were coming out, and largely, thankfully, due to the untiring efforts of Kathy Te, the PCS CANCOM was also coming up with the approval of the board, of course, certain infographics on cancer, whether it's head and neck, breast, colorectal, as well, which are for surgeons, and then also infographics for patients, and they are in English, they're in Tagalog, and then they are also translated into the various dialects in the country. So those were all the guidelines that were created during the height of the surge. I know it's still ongoing, and the Board of Regents is still looking at the situation, and future guidelines will be coming out depending on how these scenarios play out. We would love to hear your feedback on these guidelines. We heard that a lot of hospitals and surgeons would use them, but certainly they're not cast in stone. There is still a lot of guidelines that need to come out as the situation unravels. Also, there are some things that might need to be changed, no? And one of the things we're looking at is when the lockdown is lifted and when hospitals want to resume seeing previous patients that are non-COVID but require, for instance, surgery or radiotherapy, chemotherapy, what are the guidelines needed as we reopen these services? So it's still a work in progress. We would love to hear your feedback. Thank you very much. That's the end of my presentation.
Thank you, Rami. May I now call on Dr. Rodney Dafitas, one of the members of the COVID team in PGH, who will share with us the PGH experience. Rodney.
Thank you, board, my fellow members of the Board of Regents. Thank you, President Chito, and all of the rest in the EXICOM. And thank you, Kathy, also for facilitating all of this. I would like to share from the guidelines to the ground. Parang ganon. That's what I wanted to show. And I shared my slides with you mainly. Can we show my slides, please?
Kathy.
Yeah. And I will just truly say how the guidelines from the Philippine College of Surgeons were used as a guide and used on the ground. So next slide, please. So I really believe that I was actually hesitant to share our story because I really believe that in this in this present pandemic, every country, every region, every hospital has its own story. But nevertheless, maybe we could share and learn like we did when Wuhan doctors visited us, sharing their story. So we could hopefully share our story with the rest of you. But as I mentioned, each and every one of you has your own story. Next slide, please. Sorry, pasensya na. So next slide, please. Parang kailangan siya i-move. Ayan, next. So way back February, late February, formed a 1 PGH team to battle this crisis. If you notice, almost all of the team in the team are a neurosurgeon, our director, Dr. Gap. The overall head of this crisis team is Dr. Orlando Ocampo, Bok, with Dr. Monroy as his assistant. The logistics head for the non-moving resource, everything that's non-moving is a urologist, Dr. Dennis Serrano. For the communications is Dr. Erickson Berberabe, a hepatobiliary surgeon. And yours truly providing all the moving resources for the crisis team. And taking charge of all the donations, monetary or in goods, is another well-known surgeon, Dr. Anthony Perez. But personally to me, most of the surgeons are here mainly because surgeons are movers and eventually shakers. They could make things done. But we have to remember that this is a fight against COVID-19. That's why we really have to understand that it's not the scalpel who will do the battle, but it's the infectious people. So for me and for us, right there above the team is the hospital infection committee unit, headed by Dr. Regina Berba, an infectious disease specialist. And working closely with her is an intensivist because yun naman yung problema those who will go into moderate and severe disease. So we have our pulmonologist head, Dr. Jubert Benedicto, another eye infectious disease, Dr. Lim, and another medical specialist working on the ground. They're the managers day to day in the wards. Another medicine person, Dr. Adet Daes. Next slide, please. Dr. Rami, thank you. You mentioned several hospitals. A couple of hospitals were identified as COVID referral centers. But I would like to inform everyone that as a COVID hospital, we are mandated to accept only COVID positive patients. And it is clustered. So our cluster is Dr. Inso there down south, the area. Makati, Mandaluyong, Manila, Muntinlupa, Parañaque, Pasay, San Juan. So there's barely a crossover. If you're a patient in the East or in Pasig or in Quezon City, there are COVID-19 hospitals that you will be going into. And there's when these patients are transferred, the personnel with them are on level 4 PPEs. And documentary requirement is quite complete. It's not just patients who just hop into the car or put in the ambulance and they go to these referral centers. It doesn't happen that way. Next slide, please. So most important of all, the new doctor is an engineer, they say. So next slide, please. This is our architect. We had an architect. He also designed the Ninoy Aquino Stadium and Rizal Memorials. He's also our overall architect in the whole hospital, doing the master planning, and our PGH engineering team transforming a 1900 ward into a modern day COVID hospital. And in 5 days, next slide, please. This was the old wards which we had before. We are very much like most of the government hospitals with large wards. Next slide, please. This was the work done. There is a negative airflow from the entrance going to the courtyard and the sides. There are a lot of vents and exhaust fans doing all of this. No? There's very little turbulence in the air when we tested this. All of the beds are capable of monitoring and being put into ventilators. Next slide, please. And that is now how it looks in actual. There is a distancing among patient 2 meters wide. From a 53-bed ward, it now became only a 22-bed ward. And has been our life ever since. Next slide, please. We designated the hospital into a COVID area, and there are non-COVID areas in the hospital. So basically, if you've been to our hospital, all the right side of the hospital are COVID areas, and all the pay floors are all COVID areas. And when you are doing these things, next slide, please, you have to think of zoning. So even if it's a COVID area, there's still a green zone. There are natural air spaces, and you just need level 1 and 2 protection. Then when you go into the nurses' ward, you could still wear a mask only here. When you go into the orange zone to the nurses' station, that's already an orange zone. And we require a level 3 protection if staying less than 4 hours, and a level 4 protection if longer. And then when you go to the patient's area, it's already a red or a hot zone. So this is, all areas are divided into these zones. Example, next slide, please. So if you are familiar with the wards, when you enter the main corridor, it's the donning and doffing area. That's a green zone. You enter the ward. All of the wards, including the ICUs, are red zones. And then when you go out, it's all a one-way traffic to another ward, Ward 3. That's a doffing area. It's an orange zone, and then back to the green zone. Next slide, please. That's also what happens to the pay wards. There's a green zone where you do the donning, go to the nurses station and the patient's room, which are pay wards, which are red zones, and doff again going out in another wing and then go back into the green zone. Next slide, please. So how about our protective gears? I think Rami covered it a bit. Next slide, please. At all times, a mask is very important. Just an ordinary mask. Next slide, please. And this is, for me, a very important slide. In any hospital, there are accounting people, executive offices, pharmacists. So they wear level 1 protection with alcohol and high hygiene. And then there are also OPD clinics, non-COVID wards, ECG station. Then we require a level 2 protection at this time. They wear surgical masks at all times. Then a goggle or a face shield is required, and then alcohol or hand hygiene. Next slide, please. Our N95 respirators, because anywhere in the world there's a shortage of N95 masks, level 3 or 4 areas only. At the start, everyone wanted to wear N95, but it's not needed. Surgical mask provides sufficient protection. Next slide, please. And in high-risk areas, the COVID wards, the ORs, intensive care units, when you do tracheostomy, bronchoscopy, gastroscopies, that's already required a level 4 protection, meaning you wear coveralls, surgical caps, as mentioned earlier in the PCS guidelines, a goggle or a face shield, double gloves, and N95 mask, scrub suits. The scrub suits is uniform for all the people. You cannot bring your own. There are dedicated shoes also and shoe covers. Next slide, please. So how about our patients? Next slide, please. We use the new case definition. They are either confirmed with confirmed COVID-19 test, meaning PCR based, and then probable, it's a suspect case but with a negative, inconclusive, or pending result. And then discharged patients are defined accordingly. Either you're improved or recovered. Next slide, please. Oh, go back, please. One slide back. And then, of course, for suspect cases, you're either influenza-like illness only, or you're also a SARI. So we use the new definition of DOH. Next slide, please. How about, yeah. So go back one slide, so Lawrence. How about the surgeons? Because all of them are physical changes in the patients. Surgeons in COVID, we use, as I've mentioned, we based it on the PCS guidelines. Thank you very much to the work of the board. Each department is required to have a preparedness handbook. We have our videos, and everything is written down. And this incorporates the PCS guidelines. Next slide, please. So how about the manpower? Basically, in the COVID areas, there are 100 in a day. Basically, a team works for 7 days on 8-hour shifts, 153 doctors, and 153 nurses, 150 doctors, and 50 others. Somebody, it's a different person who takes the blood, another person takes the ABG. There's radiology technicians who do x-rays. Basically, x-rays are the most important tests. The CT scan is just beside it. In that area, we have a CT scan just beside Ward 3. We have a dialysis center inside that complex also. And most important for any team is the sanitary workers. They disinfect the area 3 times a day, and then they clean the bathrooms as often. Next slide, please. Next slide, please. And then staff welfare. So manpower is not only coverage of patients, but we provide health worker safety in the workplace. We try to do zero morbidity and mortality among those health workers. We provide post-duty housing for conducive fast recovery. So we house almost 1,000 plus health workers. We recruit additional health workers based on the DOH recruitment program. And at present, there's a sizable number of there's a number of doctors and number of nurses. But most important are the support people. It's very hard to get med techs, rad techs that will augment your hospital. And then we standardize all our training using the hospital infection control unit. Next slide, please. So the lead departments in the wards and in the ICUs, as mentioned, is the Department of Medicine. All the rest of the departments contribute around 5 residents per day in the workforce. The blue ones are in addition to the medicine department, surgery, neurology, and neurosurgery, because these residency programs have ICU experience. So surgeons also man the ICUs. We share it with the neurologists, IM, and neurosurgeons. Next slide, please. For the triage area, we leave it to the Department of Emergency Medicine. For the operating room, it's all the cutting departments and the Department of Anesthesia. We have a health service manned by the Department of Family and Community Medicine looking at personnel concerns. Next slide, please. So the number of beds allocated by DOH with it could be ramped up. Presently 130 beds. We are presently almost at the brim of 121 patients, 105 COVID positive, and 16 are probable, waiting for the results. Next slide, please. Maybe you're also interested on the PPE usage each day. With those number of personnel, we are roughly around 450 to around 500 PPEs a day. And these are all level 4, mostly level 4 PPEs when you go to the COVID areas. And based on the guidelines also, there are level 3 people who just come in less than 4 hours. Next slide, please. There are a lot of concerns how health workers, are they exposed or in close contact with a COVID patient or a COVID health worker? So we made definition for that. So if you're 6 feet away like that, or without a proper PPE or unprotected, you have an exposure or close contact. We have all these definitions. Next slide, please. We based on that, we let the healthcare worker assess what level of risk she is, and also so you could find your risk. And if you're low risk, you may go back to work or just self-monitor. And if you're medium or high risk, you quarantine yourself for 14 days. So this is the importance of this slide. Next slide, please. And many also ask for testing. Everyone wants to do testing for themselves. We don't do routine testing for our healthcare workers, only those symptomatic. Next slide, please. Next slide, please. So if they have the fever, cough, sore throat, and tiredness, that's when we do it. Next slide, please. Yeah, so the testing process for those, we collect the specimen using a nose swab. It's in our center, it's done by the dentist volunteers, now the ENT, and also the HICO nurses. That specimen is transported, extracted in the laboratory, and the results come in after 48 hours, 2 days. Next slide, please. So we have other services. Next slide, please. For patients, because they're so lonely, even if you get to talk to them, they're very happy. We have a tele kumusta. So in computer based, their relatives are in a distant computer site. The computer moves from one bed to another. They talk and they're happy about it. Next slide, please. We also, as you have seen or heard a lot in the TV or radio, it's investigational, the blood donations using their serum antibodies. Next slide, please. We have a Bayanihan Operation Center also. Next slide, please. Thank you, Board of Regents. Thank you, Rami, for mentioning this. We have step-down facilities because the City of Manila has used the Ninoy Aquino Stadium and Rizal Memorial Stadium as step-down facility. So if you are COVID positive but asymptomatic, we move you to that area. It's also the same as the World Trade Center and the PICC. Next slide, please. Most of our hospital workers living nearby just bike, so they become healthy because there are no transport nowadays. Next slide, please. We give them a lot of tips, what to do so that their house will be safe. Next slide, please. We tell them that it's important not only is their work, but their family and their co-workers and their communities. Next slide, please. And most of all is that they have to take care of themselves. And for me, my experience is the greatest enemy that we have is fear. And fear that is driven by sometimes not correct information. So we do a lot of moral support and interventions like teaching them the proper understanding of the enemy that we have in front of us. Next slide, please. Almost done. And I think that's all. Thank you very much for allowing us to share what we have. But as I've said, each one of you is a hero. You have your own story, and I'd also love to listen to all the stories of each and every surgeon in each hospital. Thank you very much.
Thank you, Rodney. I think, Rodney, please read your chat. You have several questions, and probably you can start thinking about
Okay.
the answers. Okay, let's move on to the different provinces that will be discussed with Dr. Roel De Leon. Roel?
Thank you, Madam Secretary. Magandang umaga po sa inyong lahat. Magandang tanghali na pala. Can you put on my slide, Kathy, please? Thank you. Now, I will be giving a perspective from the provinces. And this is not purely my perspective, but this is a collation of the perspective of the different chapter presidents as well, whom we have been having contacts for several sessions already, and from other key persons also from the provinces that I have consulted. So if you look at, next slide please, if we look at the current situation, the majority of cases in the country are actually in Luzon, and particularly in Metro Manila, which is the center of COVID right now in our country. And the reported cases in the provinces came a few days after the Luzon community quarantine and extended community quarantine was declared. And a big number of cases in the provinces have previous history of travel or used to live in Manila. We felt that the 48-hour grace period after the community quarantine was declared allowed a big number of people to travel to their home provinces, and a big bulk of the cases right now that are positive in the provinces are actually those who have quote unquote escaped Manila in that 48-hour grace period. Next slide, please. So what is the response? What was the response of the provinces? Basically, there's no uniform response among the LGUs. No uniform protocol was implemented. It's different for every region according to the PCS chapter presidents. So as we can see, many of the LGUs in the provinces acted based on the inputs that they are receiving. However, since there's a very big direction coming from the IATF, most of the response was actually based on their own understanding of the situation. So some provincial LGUs were more deliberate and early in their response. One example is Davao City, Vigan, and other Iloilo and other provinces, while others were late and even indecisive. Actually, what is funny is some are even contradicting from each other. No? One case in point is here in our area, wherein the city, which is located inside Misamis Oriental, somehow have contradicting policies, and hopefully it will be fixed in time. But this is a result of the non-uniformity was because of there is no really clear guidelines coming from above on how the provinces will react. Now, this is one thing that is observed in most regions. It is that the medical community, through the different organizations, were very quick to respond and provided a lot of guidance to the LGUs. I think aside from being frontliners, I think this is one area wherein we, the medical community, the different specialties, were very, very active in guiding the LGUs in their response, especially in the early days wherein they're really at a loss on what to do. However, not all LGUs were receptive. That's what I heard also from many areas, and a lot of politics also came into play in the way that some leaders are taking the recommendation of the medical community. So the coordination also among LGUs and medical organizations like the PCS, as I've said, were different. Some are very receptive, others are not. So it's really a case-to-case basis as far as the provinces are concerned. Now, as far as surgery is concerned, many areas adopted the PCS guidelines and other guidelines. No? So we cannot overemphasize the importance of guidelines from the top organization. No? So because it gives some directions to how the regions will respond from this COVID crisis. So next slide, please. Now, these are the key factors, and I will also be going on some recommendations as necessary. So one of the key factor, I think, on the difference in incidents from Metro Manila or from Luzon to the different provinces is the Philippines is an archipelago. So it could have been very, very much easier for us to control, especially the island provinces, because it is very easy to close this area. The only problem really is how to sustain the economy and even the food security of these islands in the different provinces. But I think this is one reason, and I also have some talks with Dr. Boogie Montenegro on this, and this is one reason why probably the incidence in the provinces is way different from that of Manila and Luzon. If you will look at the incidents currently, the most updated, the province with the most number is Davao with more than 80, followed by Cebu with more than 40. And these are somehow big areas, big land areas as well. If you look at the provinces where they are basically islands, the incidence is ranging from 1 to 5. No, so that's one thing going for us as a country. So I think the control really, and the probably if there would be a need for extended lockdown, it would just be in the landlocked areas, particularly in Luzon. Now, one key factor also is the 48-hour window. No? So if I have a lot of talk with many from the provinces, and they've been saying that sana when the 48-hour when the quarantine was declared, there should not have been any more window. So if there kung hindi sana nagbigay ng window for the people to travel, 48-hour window, mas kokonti yung mga nakauwi sa probinsya, and they could have been monitored first where they are before being allowed to go home in their provinces. What happened is because of the 48-hour window, both the symptomatic and asymptomatic were able to go home. And of course, politics will always come into play, especially in the local. The local politics is completely different. It's more dynamic and it's more difficult as many of our co-health workers are experiencing in the provinces. Of course, lack of medical infrastructures, lack of PPEs, and one more thing is the provinces learned from the chaos in Manila. So somehow a lot of areas were able to adjust, learning from the chaos that's happening in the capital. So one thing that was also noticed is there's no real pandemic plan of action anywhere. We don't really have one. We don't have a national pandemic plan. We don't have a local pandemic plan. We don't have any plan at all. We have seen that when this is happening right now, we are all cramming into coming up with all the plans. Now, effective quarantine. It's also the quarantine issue was also different from other areas, and of course the lack of testings. These are issues. Protection for healthcare workers cannot be overemphasized. And then again, we felt also that the IATF guidelines should be different for Visayas and Mindanao. Now, lastly, internet technology saves our day. A lot of communications are really through internet, through online, and this is, as they said, this is the new normal. Next slide. Do you still have a slide, Kathy? I think that's my last slide. Thank you.
Thank you, Roel. So yes, that's one of the questions, Darren. What happens after the enhanced community equipment? So community quarantine. So may I ask Dr. Dexter Eisen to talk on how do we approach the next phase of the pandemic?
Thank you, Madam Secretary, may I request the gorgeous moderator to open up my slide? Madam Cathy Te.
Multitasking kasi.
Yes, sir. Yes, wait lang. I'm looking for it.
Yes, nevertheless, we are so much eager to go back to work. Yung third slide, Cathy. Prayer kasi ang kanina. Next. We are definitely so much eager to go back to work, but the next question that comes to our mind is when we will be permitted by the government, considering that we do have an enhanced community quarantine, basically in Luzon, and more especially in the National Capital Region. So my session is all about post-ECQ scenario. How do we probably can approach it based on evidences presented to us by the CDC. Next slide, please. I made a listing of the past cases that were gathered by DOH nationwide, and so how we are at par with the COVID virus, and how or when I can predict personally the flattening of the curve. I was gathering some evidences, but let's see if we could predict based on this data presented to us from March 31 up to yesterday. I cannot see much light to it. Next slide, please. In fact, I can only see a good story somewhere in the recovery. Yesterday was the highest recovery for the day, and that was 82. And we all know that all the other numbers here are really not the reality, simply because we do not have much testings around available for everyone. Perhaps even the death is not really a reality score, simply because of that deficiency of the test. But nevertheless, what has been gathered, next slide please, and this evidence, which was made by UP COVID-19 pandemic response team, was kind of informative in order for us to project whether we're reaching the flattening of the curve and when perhaps we can expect the lifting of the ECQ. In this Luzon-wide ECQ, is this Luzon-wide ECQ effective? That was the question for this study. This is a time series analysis which shows that it now takes a little longer for the number of confirmed cases to double in number. What it took earlier, 3 days earlier, now takes about 6 days. The doubling time is now 6 days. Given with this trend, as you can see, if the reality of the scores are right, we see some flattening happening in the past 10 days. And if we would project a linear projection, perhaps we would be able to only reach around 9,000, and we will soon have the lifting of the ECQ, which I hope to happen in the next few days. We also gathered from that pandemic study that the distribution of the cases in our country and to aid in the decision-making of matters for this COVID crisis, the team continued to explore the epidemiological approaches in disease mapping at the provincial level using population density as proxy measures of the outbreak spread. You can see next slide please, that by getting the ratio of the number of cases against the estimated outbreak threshold, it can now be determined which level of the community quarantine, which could implement the different levels of quarantine levels. For instance, a province whose number of cases is at least equal or estimated outbreak threshold, these areas should implement the several levels of ECQ. These are the darker areas for which NCR, of course, is included. And on the other hand, a province whose number of cases is less than 75% of the estimated outbreak threshold may not declare community quarantine at all or may lift their quarantine level, and only needs to sustain different campaign efforts such as physical distancing, testing and contact tracing, home quarantine, and so on. So this map, which we see right now in our slides, really concentrates on Luzon particularly, and more specifically the blue areas, which is actually NCR. I was glad to hear from my good friend Roel that in Davao, they have around 80 cases already. But mind you, since the last report for NCR, we're almost reaching 2,000. And sadly, for Quezon City, which is considered now as the Wuhan city of the Philippines, it has a one-third or 33 cases of the NCR is found in Quezon City. For me, because I practice and I live in Quezon City. We also have some talks with or rather informations on when the lifting would be based on the talks of different. Next slide, please. Next slide, please. Business sector. And they propose different methods of ECQ level scheduling. Of course, these are expected bias. Their expectations are so much laid on their businesses. And they project that by April 30, this would have been modified already. The quarantine would have been modified. Going back to the real, next slide, please, topic or concern in this session, next slide, please, is whether we shall have a lifting in the, back, please. Kathy, back slide, please. One block, yes. Next slide. Next slide. Okay. Whether we shall have a lifting of the enhanced community quarantine sooner or later is not our object for this session. We as doctors or surgeons of the land should be ready for it, the possible lifting, and as the virus will be with us and will for sure travel to our workplace and hospitals or clinic. Next slide, please. I would like, next slide, Kathy. I would like us to be reminded of or reviewed of this invisible, back slide, please. This invisible enemy, the COVID-19. Really, how fast and furious is this virus, according to the president? The report number or the reproductive number, RO, as reported by CDC is between 2 to 2.5 for COVID-19 virus, which if we will compare with the seasonal influenza is definitely higher than seasonal influenza reproductive number. The mortality for COVID-19 appears very much higher than the usual seasonal influenza which we have. the crude mortality ratio of which is reported to be between 3 to 4%, and for the seasonal influenza is only about 0.1%. So the reason why we want to be prepared is because we still don't know the real reproductive number, how much it reproduced and how much we are being affected. And we do have a mortality, a higher mortality, more than the seasonal influenza. And more so, there is no known vaccine yet. Plus, we are still on the process of controlling. And therefore, next slide, please. The topic for this session is, how do we prepare for the post-lockdown period? Next slide, please. CDC gives us an advice on how we should get to our usual professional daily work. And I would just like to address the clinic readiness that we will do right after the lifting, and would like to segregate it into before patient arrives, when the patient arrives, and after assessment. The operative preparation will be made by the Board of Regents for their next statements, and this is just for the preparation of our clinic. Before patient arrives, ideally, appointments should be made for each and every patient. There should be a limit in one patient inside the clinic as much as possible. Of course, there should be triaging prior to the entry of the patient to the clinic. The sick patient should wait outside, away from the clinic premises. You may want to ask them to wait in their cars before getting into the clinic area itself. We should take care of ourselves, not only ourselves, but also our secretaries, our receptionists, with regards to the appropriate PPE. Let me remind everyone that we are acknowledged already as doctors, and there is no need for us to wear the medical gowns, the white gowns, and to avoid all the neckties that we used to wear, because this would be fomites for the transfer of the virus. I was thinking of if you could perhaps do telemedicine history taking. Next slide. Something like this, wherein which you can perhaps put up a camera and the microphone outside your clinic, and then get the history taking, chief complaint for that matter, excuse me, prior to the entry of your patients within the clinic premises. You should be able to provide waiting rooms for the patients. This should be open and well ventilated. Each person should be 6 feet away from each other, provided with alcohol hand rubs, minimal decors around the waiting area with appropriate signs. Next slide, please. And as you now get to be ready seeing the patient, next slide, please. You should be able to maintain physical distancing, appropriate PPE, and mind you, single-use gloves should be used during this time. As much as possible, limit one non-patient visitor inside the clinic. I do the practice of pediatric surgery, so perhaps I cannot avoid somebody to be with my patient. You may use appropriate barriers during history taking and limit physical contact and examination time. I'll show you some innovations that have been made recently by different hospitals and different doctors on how to limit the physical contact and examination time. Now, after assessment of the patient, we must be able to consider telehealth follow-up, notify health authorities if we do encounter patients with COVID-19 symptoms, and as much as possible, clean frequently touched items after every patient consult. The following, next slide please. The following are some things that have been taken in the web, and this is actually a very innovative kind of consultation way far from India. Next slide, please. This is, there are lots of hospitals already and clinics preparing for such event of the lifting of the ECQ. And this is like a bank teller inside the shield, acrylic shield, which you can prepare perhaps to limit the contact with your patient. Next slide, please. But definitely the use of the PPE known as the N95 is a must for this. I have been using the N95 mask. It's so difficult to breathe for me using that N95 mask, but there are available N95 masks with what we call ventilators. And it's a little bit more expensive than the normal or the usual ones available. Next slide, please. Some other things are coming up. We have the respirators, the half respirators that are being distributed by several companies. And this is just one example. The nice thing about this half-face respirators is that it is 99% leak proof with regards to the entry of particulate matters. Next slide, please. This will be our new normal. Shown in your screen right now would be the full mask, the full face respirator, which is adaptable to the respirator. This is actually part and parcel of the PAPR, which you perhaps would be able to use during your operations. Next slide, please. This is a video symbolizing, or rather representing, next slide, please. Can you please press it? The reminder for everyone to please practice the reverse isolation aseptic technique when going home. This doctor is being sprayed. It's too much already. But all I would want you to do is protect your family who's at home from the virus that you might have acquired in your clinics, so that they will be safe and would not be affected by the COVID virus. Next slide, please. Thank you. Next slide, please. Next slide. Thank you very much. And I hope we would be able to have that PCS statement on post-ECQ, how we will do our surgeries for our statement. Let's heal our land as one. Thank you.
Thank you very much, Dexter. Now is the time for the open forum, but because of the limited time, some of the questions are already being answered by some of the speakers and by some of the regions on the chat. Anyway, let me go first to a first question addressed to Dr. Gulfan. What's now the direction of the training in the different institutions now with the COVID pandemic decreasing the number of operations being done by residents or fellows in training? Dr. Gulfan? Dr. Gulfan there? Mukhang Dr. Gulfan, are you there? Okay, if none, I don't think Dr. Gulfan is listening to us. So let me go to Rodney.
I think
Rod,
Dr. Fan is there, but nakamute siya.
wala siya sa screen. Dr. Gulfan, I don't have...
Wala daw ako sa screen.
Ayan.
Okay, Dr. Gulfan.
Hello, hello.
Hello. Dr. Gulfan, the question is,
I'm here.
now with the decreased number of operations being conducted by residents and fellows in training, what's the direction of training in the Philippines for surgery?
Oh yeah. Can you hear me?
Yes, we can hear you, Dr. Gulfan. Go ahead, Dr. Gulfan.
Can you hear me, Panching?
Yes, yes, Jojo. You go ahead.
Hold on. Yeah. First of all, we are hoping that this is just temporary and short term. So, with emphasis on triage for non-emergent surgeries, eventually, hopefully, the number of surgeries will be taken care of, and we will be able to meet the requirements as mandated by the PSGS. And yeah, um, we are looking forward to the moment when everybody can go back to work in probably 6 to 8 weeks' time, and the number of surgeries will be covered.
Probably Dr. Salud
Meantime,
can...
we
Yes.
are giving emphasis on the leadership skills of the training officers and members of the training program because it's very, very important, particularly on this triage system for non-emergent surgeries. We have no issues with emergency surgeries because we address emergency surgeries as they come.
But with the guidelines for in elective
I
surgeries,
hope.
yeah. But will you be decreasing the
You-
requirements of surgeries before a resident trainee completes his training? Will you be adjusting the number of required surgeries?
I don't know if Patos is the one who should be answering that because Patos is more of for the training officers and members of the training program. Anybody who can answer that?
Dr. Salud, probably you can share with us the plan of the Philippine Board of Surgery.
Yes, regarding the Philippine Board of Surgery, the exams will have to be moved. If you recall, the Part 1 certifying exam of the PBS was supposed to be held May next month. But because of this pandemic, it had to be moved to September. Now, for the RITE of the PBS, which was supposed to be held on September 3rd, that has been postponed, and we don't know yet. The board has not decided whether to have it scheduled later in the year or to totally cancel the RITE for this year. That's the decision of the board in a recent Zoom meeting early this month.
Thank you, Chito. Before I proceed, we would like to thank first the chairman of the subcommittee on PCS website and
So
medical
it means,
informatics.
Chito, with the cancellation, those who are trying to complete, the requirements they have, they're given time to do that.
I suppose, yes, they will be.
Okay. We would like to thank first Dr. Catherine Ted, the chairman of the subcommittee on PCS website and medical informatics, in spearheading this webinar. We would like to thank also our sponsors, Amen Narini Philippines Incorporated, Telemedicine Network of the Philippines, and the DUST for technical support for this first PCS webinar. And yes, we are planning to make this a regular, probably weekly, twice a month, to include subspecialty societies. We have been meeting with the specialty societies. We had this last Tuesday, and even with the chapter. So we will be sharing with, they will become part also of these webinars. We are in the process of organizing this on a more regular uh, sessions. Okay, so probably one of the questions directed to Rodney is, how can you operate the non-COVID areas in PGH? How about the flow of patients? Rodney, are you still there? Hindi ko makita. Rodney.
Yeah, I'm still
Ah.
I'm still here. I'm still
Okay.
here.
Yes.
For now, our focus is the COVID crisis. So there are already different streams or committees working on how to restart the non-COVID areas. But again, that's even if you listen to Regent Dexter's talk, it's all still up in the air. So me personally, I'm thinking I have to finish the COVID crisis first. There are other surgeons who are working on the non-COVID part. And again, that's also a very good endeavor. Pero wala pa kami we're not yet there. We're not yet there.
Is the outpatient department in PGH open?
No, everything is it's closed. The outpatient department is closed. The emergency department is open, but again, we follow the guidelines. It's also the urgent and emergent cases that are really entertained there for now.
What about the Cancer Institute?
We have closed the Cancer Institute also for now. There are also meeting and planning to open it. But again, we have to think if you are in that area, you have also to think of the level of protection for the health workers. So they also have to be wearing PPEs. You have to think of everything, the use of resources, the use of manpower. Parang napakadaming iisipin din for the present problem.
On the lighter note, Rodney, do you recycle PPEs with the number of staff that you have in PGH?
No, we don't. When our duties are every 8 hours, and normally they rest at the 4th hour, and that's they doff and change PPE. Parang Wuhan level ang ginagawa.
And last question, do you have any infection rate data for non-COVID areas or even in COVID areas?
Ang non-COVID areas
among healthcare workers, I mean.
Yeah, we do. It was I think the rate is less than 1%, I think. There are more than 200 plus patients. There are more than 200 plus healthcare workers already tested. We are working on doing 1,000 per day at the NIH and another 1,000 in PGH daily. Before we were at the start, we were only doing 10 per day. We're now doing more than 100 per day. We'll be having 2 testing facilities soon. PGH is about to open its own. So yung target is 2,000 testing kits per day.
And probably one of the regions can answer this. What if the surgeon tested for positive? Will you allow them to go back to operating or go back to the COVID areas?
That's a common joke because I'm sorry to say it's a joke, but that's a common thought. I said when somebody says positive, you could already go into the COVID ward because as we mentioned, all our wards are only for COVID positive. Of course, it's a silly thing, but because everyone that goes there is in full PPE. So, by the way, if a person turns out positive and turns out negative after 2 testings, he still is not allowed to go back because there's still, even if he turns out negative, there's still a lot of time for the shedding period. Again, that's very philosophical question. Siguro. As I said, we always refer to the infectious people regarding these questions. We are not the experts here.
Okay, for Roel, what about the coordination between the LGUs and the different hospitals. What do you think about the networking of hospitals in certain localities?
I can only, regarding the coordination, I can only speak about our experience here in Northern Mindanao. I think we have a very good coordination between the COVID referral hospital and the private hospitals. There are regular meetings held with the center, with NMMC, with DOH, and the representatives of the private hospitals. And the current plan here is we will first refer all cases to the COVID referral center, and once the COVID referral center would have an overflow, the private hospitals are ready to take in the patients also. So having said that, for example, our institution right now have prepared a floor to prepare itself for the coming cases possibly, because according to some infectious disease specialists here in our region, the possible surge will still come a few more weeks from now here in Cagayan de Oro. Possible, I'm saying, and we just hope that it will not happen, of course. But everybody has to prepare. I think this is also true with other cities and other regions. We will not probably have the same surge as or same peak as in Manila, because as I have mentioned in my talk a while ago, probably the infection time is different from Metro Manila and in the provinces. So we should not be very lax as well. We should be thankful, and we just hope that it will continue. But we should not be very lax in saying that wala na kami, okay kami kasi walang dumadating or ano. We should still be very, very watchful in the different provinces. So therefore, very, very important talaga yung coordination ng public-private coordination. And ang suggestion talaga, if for example in some area where there's not much initiative from the local government or the other agencies, I think the private organization should be the one to initiate the coordination with them.
Okay, thank you, Roel. Rodney, there's one question. Rodney, how do you propose or recommend the rational use of PPEs? Probably PGH have lots of PPE donations, but how do you propose if there's a limited number of PPE? Rodney? Or probably our President, Dr. Salud, what's your experience in TMC?
Regarding what, Panching?
Rational use of PPEs?
Oh yes, we limit it to, of course, the COVID areas and in the operating room for those undergoing surgery for emergency cases. Although there are some semi-urgent and urgent cases that are already being done. So everyone in the operating room is required, whether the patient is COVID positive or not. As to the rational use, fortunately, we have a lot of donations. So even if maubos, we still have incoming donations. But it is probably best if some hospitals do not have a sufficient amount of PPEs. I suppose it can be reused, disinfected properly, and that can be used so long as the disinfection process is done properly.
Okay, so most of your questions are being answered on your chat. Let me see. Kathy, are there questions in YouTube?
Yes po. Let us answer the question of Dr. Arman Crisostomo on the rationalization of the use of PPE. Would anyone like to answer that?
I think that was answered already. Can anyone answer that? Add more, Rodney? Can you add more explanation on the rational use of PPE? Rodney.
Hello, hello.
Yes.
Sorry I missed the discussion. I was just answering a call.
Um, regarding the question of Dr. Crisostomo on how do you propose or recommend the rational use of PPEs?
Oh, for me, just following the recommendations of the infection control unit. Meaning to say, there are times even if you're in the red zone, but you don't have to stay very long. You don't have to wear full PPEs, level 4 PPEs. Because at this point in time, even in our experience, when a resident, a doctor is signed or goes through a red zone, whether it's ICU within the patient, they demand that they will wear full PPE, level 4 PPE kaagad. Even if they'll just see the patient sandali lang or may gagawin ng sandali sa patient because of the level of fear. So for me, it's the knowledge on the how and when to use the PPE that will make its use rational.
I think, Madam Secretary,
Yes, go ahead, Ruel.
I think that's a very good point from Dr. Crisostomo, and that has also been my concern ever since. That number one, we lack PPEs. We don't have much PPEs, and we can see in many posts, in many instances, we can see people who are wearing full PPEs when probably it is not necessary, even in areas where there is no community transmission and there's only one case coming from another area. I've seen that also, and I think as we should also look into that and make the necessary recommendations on the proper use of PPEs. What the college has done already is we made a recommendation on what is a PPE, and sadly the reason behind when we look into that recommendation is the possibility of recommending alternative PPEs. But based on our search and on our search in the literature, we cannot recommend, as a college, we cannot recommend alternative PPEs in as far as safety is concerned. However, there might be a role on the modified PPEs depending on the level of possible infection, and that's really a very good point. And maybe in the coming days we can again come up with more detailed guidelines on how to rationally use the limited number of PPEs that we have in the country.
There, may
Ahead,
I
Rodney.
share?
Yes, Rodney.
Not all surgeries seem. Before I had the thinking, also I must admit that for me, all surgeries would require level 4 PPEs. Because I'm with the health workers. My work is the health worker safety most of all. So that was my mentality before, that for all surgeons in the operating room, I will demand, in my mind, I will think they have to wear level 4. But there are some operations, like for example, that don't need to be intubated. They're really non-COVID. And again, if we do all the testing, we'll know whether they're COVID or not. But in the absence, these are very minor surgeries, very short, and the recommendation even of the ACS or HICU, they just require a level 3 PPE. So we just have to balance again the safety of the health worker first. And as I've said, no one is an expert here. We're still learning a lot, and we're still evolving also.
Thank you very much, Rodney. Unfortunately, we have limited time already. We have already consumed our time. So
One
let
more,
me thank.
Panching.
I'm sorry, on. Yes, Kathy.
Yeah, I just add on to the PPE, since there really is a lot of question on the use of PPE, on the reuse of PPE, and also disposal of PPE. And this is really very important for all of us to understand that it's not just simply the rationalization of the use of PPE. The most important thing is screening, triage, because the decision to use level 4 PPE, enhanced PPE, remains on the characteristic or the clinical feature of the patient. So we need to screen the patient very well. And it's not just the usual screening of history, PE, or with or without tests. And remember that a lot of these patients will be asymptomatic or pre-symptomatic, especially when they are, as we go into the post-ECQ state, where these patients will come in for their delayed surgeries or their postponed surgeries. And we need to take all of these into consideration because there are asymptomatic patients, there are pre-symptomatic patients, and several tests needs to be done. The recommendations are still really very difficult to follow very clearly based on the infectious diseases point of view and from the surgical point of view, because we have different interests. The infectious diseases physician's interest is on the patient and on the resources, while the surgeon's interest is not only on the patient and the resources, but also includes all the aerosolizing generating procedures that will be harmful to a lot of healthcare workers inside the operating room, especially when we are not properly equipped. So screening and triaging of these patients remains to be the most important factor in deciding whether we use what level of PPE. Likewise, this will help us in the disposal management, the reuse management, and all of these will need another session to discuss. So perhaps we can leave it at that, and then hopefully by next week and a couple of weeks to come, we would be able to invite some of the experts in the use of PPE so that we can address this concern. Another thing that I would like to add there is that because a lot of us are not familiar with donning and doffing of PPE. So I think in the beginning, it was really necessary for everyone to try and be able to standardize the procedure to simulate it so that we won't be breaching the principles in donning and doffing. So at this point, we already have COVID designated centers, and we should take advantage of this because we don't need to waste further PPEs in donning and doffing simulation if we already did those. Likewise, we need to allow the COVID centers to be able to focus on their job and also centralize our resources for these things. I hope this helps, and I hope that we would be able to come up with more answers to your questions. Thank you.
Okay, thank you, Kathy. Thank you for spearheading this webinar. We would like also to thank again Amenary in the Philippines Incorporated, Telemedicine Network of the Philippines, and the DOST for the technical support in conducting this PCS webinar. Anyway, thank you very much for all the participants, those in Zoom and those in YouTube. We take note of your comments in the chat group, and rest assured that the PCS will come up with more webinars probably next week again. We only had a few days to organize this first PCS webinar. So thank you once again. Thank you, Board of Regents. Thank you to the other fellows and other guests that attended this
Thank you,
session. Thank
Panching.
you very much.
Bye-bye.
Hey.